So this video was recorded in 2008. A patient suffered from traumatic spinal cord injury at the level of T12. And this video showed our method of neuromotor recruitment. We asked the patient to imagine his lower limb and try to recall the image of his lower limb in his head, in his brain, and then to rehearse the movements of the extension of the lower limb. So the problem here is the reconnection between the upper part and the lower part. The basic of this method is to work with the brain to send signals to the site of the lesion in the spinal cord by the motor imagery, for example, and to work also in the same time from the periphery with the muscles in order for the spindles to send signals to the site of the lesion. So working with the motor imagery from the up and working with boots of stretching from the down will meet in the site of the lesion and will induce recovery post-spinal cord injury. In this way, we can stimulate the site of the injury and try to reconnect the up to the down. So we can see in the video how we can send signals from the muscles to the site of the lesion of the spinal cord. We can stretch bilaterally the lower limbs and then try to ask the patient to extend his two lower limbs. So in this way, we can send from the spindles some signals to the spinal cord, working with the bottom-up model. And from this way, we can tell the patient if he feels some tension or some tightness in the hamstrings or any muscle of the lower limb in order to stimulate his perception of his muscles in the extremity. We can make stretching as we want, or unilaterally or in bilateral mode in order to stimulate or to make the patient more perceive his lower limbs. In this way, we can increase the tension and ask the patient to feel this tension by on-off mode. So when we make the boots, we ask the patient to feel it. When we turn off the boot of the stretching, we ask the patient also to feel the difference. In this way, on, off, 0, 1, stretch, non-stretch, and we can stimulate these signals from the down to the up. So after the stretching, we ask immediately the patient to try to move his lower limb to see if there is any reconnect between the bottom and the up. So in this way, we can ask the patient to move in an explosive way his lower limb and see what is the effect of our technique. Of course, this technique of stretching will follow a technique of motor imagery in a way that the patient can imagine his lower limbs inside his brain and try also to reconnect again the up to the down. So in every time we must check if this technique is effective in the patient, if the patient understands what we mean by perceive or by feeling his lower limbs, his muscles, and try to reconnect his lower limb to his brain through the lesioned spinal cord. In this way, when the patient understands what we mean by this technique, the effect will be maximized. Also, we try to invest this recovery, this spontaneous recovery, by asking the patient to make some functional transfer or some functional movements in order to use this recovery and try to maintain it and restore it if this possible, and to work with it if possible at home or in his room. And we can see that the patient can move his limbs better, and he can perceive even the posture and the position much better than before.